So moving into the next session, which will blend physiology and critical care together, I'll hand it over to the moderators.
Okay, so we will go ahead and get started with Dr. Bradley Wertheim, one of our colleagues at the Brigham and Women's Hospital, and I'm very thrilled to be able to introduce him. He trained in medicine at Harvard, did residency at MGH before he completed his pulmonary critical care training at Brigham and Women's Hospital, including being the first person to participate and be the recipient of the Burke Pulmonary Vascular Disease Program. And now he is on clinical staff at Brigham, but also has an active research program that he helms. And so he'll be talking today about vasopressor support in RV failure. Can we optimize RV mechanics and coronary perfusion? Take it away.
Thank you very much for the introduction. And thank you for the opportunity to speak today. So I am a pulmonologist, and my views on right heart failure are also colored by the fact that I see mostly patients with pulmonary vascular disease. But I think the purpose of the talk and one of the main points I'm going to try to make today is that we actually need to think more beyond traditional specialty roles when considering right heart failure, in particular as we support a critically ill right heart in the intensive care unit. So we'll begin with a discussion of context, and we'll make the argument that there are many different subphenotypes of right heart failure in the ICU. And as the focus of today's talk is the role of vasopressor support, I'm going to focus on the importance of systemic vascular resistance as a defender of RV perfusion. And then we'll touch on some key issues and controversies in vasoactive drug use. Today I'm going to focus on vasopressors, and Dr. DuBrock to follow will be talking on inotropes. And we'll discuss in particular some applications in pulmonary vascular disease. So one of the points that I like to make to trainees is that we need to look at RV failure and also pulmonary hypertension as more of a syndrome than a disease. In many respects, it can be viewed as a final common pathway of many diseases. For example, right heart failure can be caused by coronary artery disease, RV infarction, cardiomyopathies, diseases of the arteriolar bed, including pulmonary arterial hypertension, CTEPH, pulmonary embolism, parenchymal lung diseases converging on ILD or COPD-associated pulmonary hypertension or other diseases of chronic hypoxemia, pulmonary veno-occlusive disease, and other conditions such as LV failure that are known to affect pulmonary veins, and then finally, forms of left-sided heart failure. And as Dr. Haddad eloquently mentioned earlier, there are many interrelationships between RV and LV function, and such that I really like to view RV failure as a failure of the integrated cardiopulmonary unit rather than just as a primary failure of an isolated ventricle. So to discuss RV perfusion in health and disease, we first need to consider a couple of physiologic elements that have been defined over the last 30, 40 years of research. For the right heart, coronary perfusion pressure is approximated by the difference between the systemic mean arterial pressure and some metric of RV filling pressure. In many instances, it's the mean RV pressure. One could also argue that right ventricular end diastolic pressure is the primary determinant of that. The right heart depends on coronary perfusion pressure via the right coronary artery to maintain coronary blood flow. Now, depicted here is a plot of coronary blood flow on the y-axis versus coronary perfusion pressure on the x-axis, and we can see that the left coronary artery has ability to auto-regulate flow. What does that mean? Essentially, over a limited window of coronary perfusion pressures, which we can see depicted in red, the left coronary artery is able to maintain flow even in the setting of a decline in coronary perfusion pressure. However, for the right coronary artery, we see essentially almost a linear relationship, whereas a drop in coronary perfusion pressure leads to a drop in coronary blood flow. And that can have functional significance. So To conclude that element, the right coronary artery really has limited ability to auto-regulate flow and therefore is very vulnerable to coronary perfusion pressure changes. Next, we know from physiology research that the right coronary artery, unlike the left coronary artery, perfuses in systole and diastole, whereas the left coronary tends to perfuse mostly in one phase. So in the setting of pulmonary arterial hypertension, and a variety of other disorders associated with elevated right-sided systolic pressures, we can see that a drop in, as RVSP rises in this population of patients with PAH and CTEPH from Dr. von Knorgraf's lab, we can see that that systolic RCA flow drops and diastolic flow predominates. Therefore, it can leave the RV vulnerable to conditions of ischemia. And we can see this borne out functionally in a study from the 1980s in a PA banding model on dogs. You can see that it's a somewhat convoluted way of depicting these data, but the bottom line of their study was that increases in RVSP lead to proportional changes in RV systolic vulnerability to changes in coronary perfusion pressure. Basically, as coronary perfusion pressure drops, you see RV systolic dysfunction. So collectively, we see that the RV in particular is vulnerable to changes in coronary perfusion pressure. Now, we are all familiar with the spiral of RV failure that can occur through integrated changes in cardiac function and pulmonary function, such that in a predisposed host, when there are acute insults such as volume overload, arrhythmia, positive pressure ventilation, hypotension, we can set forth a cycle of physiology where hypotension can lead to a hypoperfused RV that can promote ischemia, RV dilation, septal shift, which can in turn drop cardiac output, which in turn leads to impaired coronary perfusion and perpetuates the cycle of RV failure. Superimposed on that are pulmonary contributors such as acidosis, hypoxemia, changes in RV afterload that can further fuel this and lead to decreased cardiac output, systemic hypoperfusion, and shock. Now, for the purposes of today's talk, I'd like to discuss systemic vascular resistance, which I would argue is at times an underappreciated linchpin of defense against this spiral. So we're taught in medical school that systemic mean arterial pressure is proportional to SVR and cardiac output. Now, in some forms of RV failure, and I will say with the caveat, not all forms of RV failure, cardiac output can be hard to augment. And that may be in the setting of, essentially obstructive shock physiologies involving the right heart. But in these contexts, we're essentially dependent on systemic vascular resistance to defend the mean arterial pressure. And so what does that mean for the right heart? So we can see that coronary perfusion pressure, as we reviewed, is really proportional to mean arterial pressure, and it's also dependent on RV filling pressures. So if mean arterial pressure is essentially dictated by your SVR, there can be situations in the ICU in a very, very sick right heart failure patient where your right heart coronary perfusion pressure is dictated and maintained or defended by the SVR. So therapies with respect to vasopressor choice that optimize the relative balance of pulmonary vascular resistance relative to SVR are advantageous, specifically therapies that can drop this ratio. So what are our choices and what are the agents that we can use for RV support in the ICU? We can generally lump our vasoactive therapies into the category of vasopressors and inotropes, and I'm not going to get far into the inotrope territory because that'll follow in subsequent talks. But with respect to vasopressors, we know a fundamental mechanism is that they increase SVR, and depending on the agent, may have some procontractile effects. The net aggregate canon of physiology literature with these agents shows variable effects on cardiac output. Generally speaking, in most ICUs, we're talking about norepinephrine, phenylephrine, vasopressin, epinephrine. I think dopamine, in light of trials such as SOAP2 and so forth, is generally falling out of favor in most intensive care units for the support of undifferentiated or RV shock. One main concern, though, with vasopressor agents is that all of these, in part with the exception of vasopressin, have some degree of alpha-adrenergic agonist activity. And it's very well established in animal data, in isolated lung preparations, and other physiologic studies that alpha-adrenergic agonism will increase your pulmonary vascular resistance. So it always raises the question of, sure, we treat the shock, we support the mean arterial pressure, but what actually happens to right heart function? Are we increasing afterload in parallel? Conversely, inotropes are going to be increasing our contractility, many of which decrease SVR, and we all accept that in many physiologic circumstances they're increasing cardiac output. Specifically, we have the inodilator family of agents, including dobutamine and milrinone, that have a more pronounced effect on SVR. The downside to the use of these agents is patients very frequently, especially when there's already pre-existing shock, can develop worsening hypotension. These agents can be arrhythmogenic. And then keep in mind that this is a somewhat artificial distinction between vasopressors and inotropes, and it's really not a black and white, and that there are drugs that have actions for both. So as we look to the literature to guide clinical practice for the care of this very sick and highly vulnerable patient population that's physiologically challenging to untangle, it would be ideal if we had high-level clinical trial data to guide our choice of agents. And as we all know, those data are very, very hard to come by. There are some studies, there's a canon of well thought out, very sophisticated animal physiology research that emerged really in the 1950s through the 1990s. But as funding priorities have changed, you see less of that kind of data coming out. But ultimately, we know that people are not lab animals in highly idealized situations, and we would like clinical trial data. But the clinical trial data and the clinical data that are out there are often from very specific clinical contexts. So there's data on sepsis. There's, probably one of the larger canons of data out there is in post-cardiopulmonary bypass, right heart failure, cardiac surgery populations, which, is a large percentage of patients we take care of, but it may not be necessarily extrapolable to a patient with pulmonary arterial hypertension and septic shock, for example. So one of these studies that does do a nice job at comparing in side-by-side fashion the strengths and weaknesses of various agents was a double-blind randomized controlled trial where they tested the effect of vasopressin versus norepinephrine for milrinone-induced hypotension following cardiopulmonary bypass. This trial did not include pulmonary hypertension patients. It was small, but the goal of it was to increase mean arterial pressure by 20%, and all these patients had swans, and it was double-blind, so it provides some scientific rigor to back the findings. So at a median dose of about 0.06 units per hour of vasopressin, they saw increased SVR as we might expect. They saw no change in PVR, and leading to the two processes together led to a drop in the PVR to SVR ratio, which was statistically significant and different than what was observed in norepinephrine. Norepinephrine at a modest dose of 7.5 units per minute indeed increased SVR. It also was observed to increase pulmonary vascular resistance and therefore had a neutral effect on our PVR to SVR ratio. In this clinical context, neither pressor influenced cardiac output. However, the trial of 25 patients per group was really too small to draw any meaningful clinical conclusions from, but it is directionally concordant with some of the data we see from the animal physiology studies. Comparative data on epinephrine as it sits with other vasopressor agents, is surprisingly hard to find in humans. There's a lot of good data in animal preparations. This is a small study in pediatric pulmonary hypertension patients where they kind of performed a similar physiologic analysis looking at the net effect on PVR to SVR ratio. And as we might expect, we see a decreased effect on pulmonary vascular resistance for vasopressin, keeping in mind that vasopressin's not an alpha-adrenergic agonist and bears out directionally similar findings to what we see from animal studies. However, the question to be raised that is yet to be really clarified is this clinically important? So, a provocative study that adds to this debate is a classic physiology study from the early 1980s done by Vlahakis and colleagues at MGH. And for the purposes of trying to, I think, be a little controversial for this talk and stimulate some discussion, many of us in the ICU are trained in the paradigm that when you have a sick right heart, you need therapies that target right heart contractility to ultimately improve cardiac output, improve perfusion. That may be true, but this study is provocative in that it actually does not, it shows that you may not actually need procontractile agents to do this. So it was achieved in a dog model of pulmonary arterial banding with a closed pericardium, which is important to consider for the physiology, where RV failure was induced by progressive banding of the PA to the point on which the RV end diastolic pressure rose, thereby designating RV failure. And what they observed when they initiated phenylephrine versus control was that even a pure alpha agonist such as phenylephrine was sufficient to augment cardiac output, presumably through an increase in coronary perfusion pressure. And that was paired with a biochemical analysis of snap-frozen RV myocardial tissue where they saw improved RV bioenergetic markers. They concluded that in this model, of fixed RV afterload, which I will grant that applies to only a subset of the patients that we're probably taking care of in a critical care setting. A pure alpha agonist such as phenylephrine was sufficient to reverse RV myocardial ischemia and actually increase cardiac output, even though many of us are taught that vasopressors without beta-adrenergic effect don't have a significant procontractile effect. And we would infer that this is probably due to improved RV perfusion pressure. So I think based on these data, we in the ICU need to derive some sort of pragmatic clinical workflow for how we think through right heart failure. And keeping in mind the caveats that we said, that we need to think more integratively across the cardiopulmonary unit and not just think of right heart failure as a monolith, a single syndrome. I think one way of looking at things is we can subset some of our right heart failure patients into a bin of pump failure. These are folks with post-cardiopulmonary bypass right heart failure, potentially RV failure after implantation of a VAD, cardiomyopathies, RV infarctions, and so forth, in which we can reason that a primary lesion for them is probably a failure of right heart contractility. So, to treat that, I think that would be the appropriate physiologic target to choose our pharmacologic support. So, an inotrope plus or minus some vasopressor support to maintain a mean arterial pressure seems like a reasonable goal. A lot of discussion on rounds in the ICU focuses on agent selection, and a lot of the physiologic data that I've presented, only a small subset of, compares different vasopressors in various animal models of pulmonary hypertension. But we actually focus less on how to use those agents as well. I think we can all understand that, a Levophed at 2 is probably a different drug than Levophed at 45. So mean arterial pressure target is probably an important part of this conversation. And there's essentially, already in an all-comer ICU population, this has been looked at in sepsis and shock as a whole, leading somewhat mixed results. Maybe higher MAP targets improve renal outcomes in a subset of patients. But you could imagine that this might be germane to right heart failure and largely remains understudied, underdiscussed. And then I think we also need to emphasize the importance of good kind of RV hygiene, supportive care, maintenance of appropriate rate, rhythm, volume status, and keeping in mind that the right heart also exists inside an entire body, and we need to optimize all organ systems to try to optimize right heart failure. On the other side, I think we can bin patients into afterload problems, one of which is obstructive physiology. And what does that mean? I think these are folks with lesions of the pulmonary vascular bed that more or less are sometimes hard to reverse over a short time scale of minutes to hours. These are things like pulmonary arterial hypertension, ILD-associated pulmonary hypertension, CTEPH. We can see patients with pulmonary embolism. And then we also have to keep in mind that there are certain valvular cardiac lesions that present relatively fixed afterload to the right heart by virtue of pulsatile and non-pulsatile loading. I love this quote by Dr. McLaughlin where she makes the case that, PAH, for example, one way of thinking about PAH is that you can almost consider it a fixed cardiopulmonary lesion with physiology similar to aortic and mitral stenosis. And even sometimes, one can argue that, anytime you're in a situation of right heart failure where afterload can't be modulated very quickly, there are some physiologic parallels to those conditions. To treat the right heart, the goals would be to somehow alleviate this obstructive physiology, all the while maintaining or potentially even augmenting SVR. And in a situation like this, when faced with RV failure, a reasonable initial approach would be vasopressor support to maintain coronary perfusion pressure. And then also, obviously, at the end of the day, we have to treat the underlying physiology. You have to treat the PAH. You have to treat the CTEPH. If this is RV failure because of critical aortic stenosis, obviously, it's not going to get better until the fundamental lesion's addressed. And then we converge on our pathways of supportive care for the right heart. And then I think another phenotype of right heart failure that we see in the ICU is right heart failure driven by pure left heart failure. Heart failure with reduced EF, preserved LVEF, regurgitant valve lesions, in which case, the best therapy for the right heart is ultimately going to be to get that afterload down, deal with the valvular problem, involve our cardiology colleagues. And in this case, augmenting SVR could be detrimental to left heart function. This is a kind of a classical cardiogenic shock patient, and you want to warm them up, optimize LV function, avoid hypotension, and adhere to supportive care. So to summarize, I think we should recognize, and we all do recognize at the bedside, that our RV failure is not a monolith. There's many, many different subphenotypes, and we really need to individualize the resuscitation of the right heart. I think we recognize that SVR can defend right heart perfusion, especially in those situations where the cardiac output may not be able to be readily augmented in the setting of obstructive type physiology. I think, if I had to put my money down, most of us would argue in the ICU that hypotension is probably a bigger threat than the theoretical increase in pulmonary vascular resistance that your vasopressor may be creating. Although the full, the caveat of that is that we really, this is this is gathered from, and extrapolated from a wide variety of non-human data, so we don't really know the clinical answer to those questions. We need to individualize the right heart resuscitation to the patient. And what does that mean? Well, I think the clinical context matters a lot. Is this sepsis? Is this cardiac surgery? Is this pulmonary embolism? Is this pulmonary arterial hypertension? They all probably have their own optimal approach that we really haven't teased out in a systematic way as investigators. I think comorbidities can also be an important guide of how we resuscitate the right heart. You know, if the patient has AKI, using milrinone may not necessarily be the best idea. If there's pulmonary arterial hypertension, we obviously need to treat that, and so forth. Arrhythmia and risk of arrhythmia and its effect on right heart function is important, and we know that various choices of vasopressors have different risk for arrhythmogenicity. You know, you go into some units, some hospitals that have kind of fairly fixed and regimented views on the resuscitation of RV failure, and they say, oh, you know, RV failure patient, you got to get them on milrinone, you got to get them on epinephrine, and that's just not true. And I think this reflects, you know, as I think was brought up in the last discussion about how we think about echocardiography and interpretation, reporting, standardization. I think as a field, we need to make education of a clinical priority such that we're thinking more about these issues outside of highly specialized contexts in rooms like this, but it really needs to reach our colleagues out in the ICU who are not right heart failure specialists, our colleagues out in the community, and so forth. I think we can gather safely that vasopressin has a pretty favorable pulmonary vascular resistance to SVR profile, but you know, we know that the dosage and potential off-targets effect of the drug sometimes limit our ability to use that as a single therapy. So I'm going to go out on a limb and say, you know, if I was on, you know, I think we can conclude that there's no first-line choice here, and we're going to have to individualize it. But what I was about to say is I'm going to go out on a limb here. If I was stuck on a desert island with a patient with relatively undifferentiated right heart failure, as an intensivist, if I had a stick of Levophed and norepinephrine, you'll probably be able to do right by many of your RV failure patients. If you have to choose a single agent to start first and you don't have a lot of time or choice. I think if there's not a lot of risk for arrhythmogenicity, an argument can be made for epinephrine given that it is a fairly balanced drug. But I will leave the discussion of inotropes to the discussions that follow. So I'd like to thank you for your time and thanks for the invitation.
Thanks so much. That was a great talk. I'm excited to introduce our next speaker, who is Dr. Hilary DuBrock. She is a pulmonary and critical care doctor and a pulmonary hypertension specialist at the Mayo Clinic in Rochester, Minnesota. She is an associate professor in the Division of Pulmonary and Critical Care, as well as the Department of Cardiovascular Medicine. She completed her fellowship here at the combined Harvard program and got her master's through the Harvard Catalyst program, and then joined the staff at the Mayo Clinic. And her research interests really focus a lot on patients with cirrhosis and associated pulmonary vascular disease. And today she's going to talk to us about inotropic support in RV failure. Is there really a role? Thank you.
Great. Thank you for inviting me here. It's nice to be back in Boston. So I'll be talking about inotropic support in RV failure. Is there really a role? These are my disclosures. And so I hope that by the end of this talk, you'll be able to define the different inotropes that we use, their mechanisms of action and common side effects. We'll review indications and guideline recommendations regarding inotrope use in right heart failure, and also discuss some clinical scenarios in cases where inotropes may or may not be helpful. And so I thought we'd start with an informal poll here, and everyone just raise your hand, but what's your preferred inotrope? Dobutamine? Got a few takers. Milrinone, maybe a little bit more. Epinephrine, big vote over there from Nick. Norepinephrine, oh, a few. Dopamine, no, okay. No takers for dopamine. Levosimendan, or maybe our Europeans in the room, and then it depends. And so a few votes for that. And so when given this assignment to prepare this talk, I started kind of asking my friends of, you know, what's your preferred inotrope, and was really shocked how much heterogeneity there was. And I think we can see that here in this room too. I don't know if everyone looked around, but There's a lot of differences in terms of what people use as their preferred inotrope, and that's pretty reflective based on the experience that I've had as well and when I was asking other individuals. And so let's start with the basics. I'm a simple person. So what is an inotrope? The title of this talk is Inotropes and Right Heart Failure. So let's break that down. Well, an inotrope is any medication that increases cardiac contractility, thus improving cardiac output. That sounds like a good thing. Examples include some of the ones that we just discussed: dobutamine, milrinone, levosimendan, dopamine, epinephrine, and norepinephrine. And then how do we define right heart failure? Well, as mentioned, it's really a syndrome. It's this clinical syndrome that's characterized by decreased right ventricular function that leads to insufficient blood flow and or elevated filling pressure. So there's really two major characteristics: signs and symptoms of low cardiac output and signs and symptoms of venous congestion. And we know that. I like this quote from one of my colleagues at Mayo Clinic who wrote this review article, that the function of the right ventricle really determines the fate of our patients with pulmonary hypertension. And that's why we're all here today, too. When patients get admitted to the hospital with pulmonary hypertension, they have a high in-hospital mortality. And once you superimpose right ventricular failure on that, their mortality is even higher. And the patients that are admitted to the ICU have a 40 to 48% in-hospital mortality. And these are the patients that we're often thinking about using inotropes. So it's important to understand that context of the patients that we're discussing today. And so why do we use inotropes in right heart failure? Well, we don't have a targeted medication for right heart failure, so we use inotropes to hopefully improve their cardiac output and their RV function with the goal of trying to improve their clinical outcomes and survival, even though there's not great evidence to support that. So what is the evidence for inotropes in right heart failure? Well, there's a lack of high-quality evidence for use of inotropes in actually the majority of conditions, even left heart failure, but definitely a lack of high-quality evidence for right heart failure. And that's why I don't have a lot of kind of fancy figures and references and tables, but rather kind of random icons like this in my talk, because there's really not a lot out there in terms of evidence. And so there was a meta-analysis that found that there's really no convincing data to support any specific inotropic strategy in cardiogenic shock. And so that was looking at patients with all comers with cardiogenic shock. So why do we do it? Why do we use inotropes in right heart failure? Well, there's not a lot of evidence for a lot of things that we do in daily life and in clinical practice. I compare it to, using a parachute to jump out of an airplane. There's not robust evidence for that. And it would be hard to design a, prospective randomized controlled trial. Probably be very hard to recruit patients. And similarly, it's hard to design these prospective randomized controlled trials for our patients with right heart failure because they have such a poor prognosis when they're admitted to the intensive care unit. And so what about left heart failure? Well, there's consensus recommendations about indications for inotropes in left heart failure. And these include congestion refractory to diuretic therapy, hemodynamic optimization prior to LVAD, palliative care as a bridge to heart transplantation, or assessing reversibility of organ dysfunction prior to consideration of LVAD or transplant. And so a lot of these applications could potentially be extrapolated to right heart failure. But can we really extrapolate data, indications, and evidence regarding inotropes in left heart failure to right heart failure? And I would argue that we can't. The right heart is not a little left heart, just like children are not little adults, right? My children certainly are not little adults. And so we can't necessarily extract that data to our right heart failure patients. So what do the guidelines say about right heart failure? Well, the most recent 2022 European guidelines state that when managing patients with right heart failure in the ICU, it is recommended to involve physicians with expertise, to treat causative factors and use supportive measures, including inotropes and vasopressors, fluid management, and pulmonary arterial hypertension drugs as appropriate. And when you get into the more detailed text, they say that treating right heart failure should focus on treatable triggers. And fluid management, for example, is of utmost importance, most of whom require a negative fluid balance to reduce RV preload, thereby improving RV geometry and function. And that patients who have a low cardiac output may benefit from treatment with inotropes, and dobutamine and milrinone are the most frequently used. So it's not necessarily a ringing endorsement. They're saying you may consider using it, and these are the medications that we usually use. They also state that maintaining the mean systemic blood pressure greater than 60 is a key objective when treating right heart failure, as just discussed in the last talk, and that patients with persistent hypotension may require vasopressors. There's also been consensus recommendations, again, highlighting and supporting the use of inotropes, saying that optimizing cardiac output with inotropes such as dobutamine or milrinone is recommended, including, in addition to treating these triggering factors, optimizing fluid status and optimizing blood pressure. And so I'm a clinician, so let's talk about a case. So we have a 72-year-old female with pulmonary arterial hypertension associated with scleroderma who's on triple therapy, is intermediate high risk at her most recent baseline visit or clinic visit. And she presents to the emergency department with a urinary tract infection. Initially, her blood pressure is 98/60, which is actually pretty similar to where she runs in clinic. She's given antibiotics and then a 30 cc per kilo fluid bolus of lactated ringers, and her subsequent blood pressure is 70/40s, and she's admitted to the intensive care unit. You do a bedside ultrasound on admission, and it reveals a dilated RV with decreased RV function, flattening of the interventricular septum, and then a small underfilled LV, and a dilated IVC without collapsibility. So what's the most appropriate next step for her? You don't need to answer, but just kind of think about it. Start norepinephrine, give additional IV fluids, start dobutamine, start milrinone, diurese. Is there really a right answer? Hard to know. But let's take a step back and think about what happened to our patient. So she came in to the ICU with signs and symptoms of sepsis, and she got a fluid bolus, which is not wrong for most patients, but in her, it kind of tipped her over the edge into the top of this figure here, where her RV dilated, she developed worsening tricuspid regurgitation, septum shift, decreased LV filling, decreased cardiac output. And so a fluid bolus, which seemingly was not harmful for most patients, actually tipped her more into the shock category. And so when I talk to our learners in the ICU about fluid management and RV failure, I try to impart to them to avoid this reflexive IV fluid bolus for our patients with hypotension. I think they see, MAP less than 65, give IV fluids, and that's not necessarily the right approach. And what they need to do is actually step back and look at the patient, and our patient likely needs diuresis and not fluids. I also like this label here, which I think like all of our pulmonary hypertension patients should come with when they get admitted to the ICU, is that they're fragile, handle them with care, keep them dry, don't drop them. And that's because we want to avoid this RV spiral of death, this RV death spiral, which we've mentioned. And that's where, a simple intervention like giving fluids can worsen RV dilation, lead down this whole spiral of neurohormonal activation, decreased RV contractility, ischemia, cardiogenic shock, and death. And so it's really important when we really want to think about managing these patients of, as we talked in the last talk, was what's causing the hypotension in our patients with RV failure. And certainly, if they're dry, if they've had vomiting and diarrhea and they've continued their diuretics, give them fluids, but most of the time that's not the cause of hypotension in these patients. And it's either reduced LV filling, increased RV afterload, or decreased RV contractility, or an inappropriately decreased SVR. And so the treatment should target the underlying cause and not necessarily throwing inotropes at all of our patients who come into the ICU with RV failure. And so our patient was started on norepinephrine. She had improvement in her blood pressure. She was diuresed. She had initial improvement in her urine output. Then over the course of the next several days, evolved more into persistent right ventricular failure, where she had lactic acidosis, altered mental status, decreased urine output despite appropriate antibiotics and management of her fluid status, and her central venous O2 sat was 42%. And so what's the most appropriate next step for her now? 2-liter IV fluid bolus, start milrinone, start high-dose dopamine, start angiotensin II, or start phenylephrine. I think, hopefully I've convinced you that you should not give a 2-liter IV fluid bolus. Milrinone, I think now may be an appropriate time, and we'll talk about that. High-dose dopamine, we tend to not use anymore, arrhythmogenic, and then it can also cause vasoconstriction. And then angiotensin II and phenylephrine would be contraindicated given the increase in pulmonary vascular resistance. And so why do we use inotropes? Well, we use them to augment myocardial contractility and the failing RV stroke volume to improve their cardiac output. And we should consider using them when there's evidence of inadequate oxygen delivery, despite optimizing RV preload and RV afterload and systemic perfusion. Risks obviously include arrhythmia, hypotension, and ischemia. And most guidelines recommend consideration of dobutamine or milrinone, but there's really no head-to-head comparisons in pulmonary hypertension or RV failure. This is just a brief summary slide of different different agents that have inotropic activity and their mechanisms of action. We've talked about dobutamine, beta 1, beta 2, and alpha effects. And then milrinone are the ones that we tend to focus on, which is a PDE3 inhibitor, which also can decrease the systemic vascular resistance and the pulmonary vascular resistance. And so milrinone is a PDE3 inhibitor. It increases intracellular cyclic AMP in cardiomyocytes, thus increasing intracellular calcium and increasing contractility. It has inotropic, vasodilator, and lusotropic effects, and it has a dose-dependent improvement in cardiac output, filling pressures, and pulmonary arterial pressures. It does require dose adjustment in patients who have a GFR less than 50, and so that's patients where you might be more cautious with using it, and can lead to peripheral and pulmonary vasodilatation, with adverse effects being hypotension and arrhythmia. In left heart failure, there's been some clinical trials looking at milrinone use, and the PROMISE trial, for example, was patients with chronic left heart failure and low ejection fraction with functional class 3 or 4 symptoms. And what they found was that long-term oral milrinone was associated with more frequent hospitalizations, hypotension, syncope, and increased mortality. And then there was OPTIM-CHF, which was a randomized controlled trial of patients with heart failure exacerbations. And they found that IV milrinone compared to placebo had no benefit on mortality or readmission. That milrinone was associated with hypotension, arrhythmias, and increased mortality among patients with ischemic heart disease. So that's a subgroup where we certainly don't want to be using them. What about dobutamine? Well, dobutamine is a synthetic analog of dopamine with mainly inotropic and less chronotropic properties. Stimulates the sarcolemmal beta 1 receptor of cardiomyocytes, leading to activation of adenylyl cyclase, intracyclic AMP, and then a release of calcium. It is an inodilator due to this beta 2 mediated peripheral vasodilatation, but tends to have a little bit less propensity for hypotension compared to milrinone. But adverse effects are tachyarrhythmias, which we tend to not be tolerated well in our PH patients. And so what about comparing these medications, milrinone versus dobutamine? So the recommendations say, consider one or the other of these agents. So there was a single center randomized controlled trial. This was in cardiogenic shock, so not specifically right heart failure. And what they found, this was published in the New England Journal of Medicine, the year is wrong here, it was actually 2021. And they randomized 192 patients to milrinone or dobutamine. And what they found was that there was really no difference at all in primary or secondary outcomes. So no difference in in-hospital death, TIA, stroke, or cardiovascular or renal events. The authors of this manuscript mentioned later in subsequent manuscripts that they have prepared and submitted a subgroup analysis of patients with RV failure compared to LV failure, but I haven't seen it published yet. There's also, looking at retrospective data, a meta-analysis where they looked at dobutamine versus milrinone, and they found that dobutamine was associated with an increased all-cause mortality with a hazard ratio of 1.19. But in that meta-analysis, they said, most of the studies that we included here were of very low methodologic quality. And also, the ones that supported milrinone use were predominantly observational and not prospective studies. And then there was a retrospective cohort study where they looked at reasons for discontinuation of medications. And milrinone was more commonly discontinued due to hypotension, whereas dobutamine was more commonly discontinued due to arrhythmia. And so potentially your adverse effect profile can help you with deciding which inotrope to use. Levosimendan, I think, is an interesting option, which I've not used since it's not available or approved in the United States, but it enhances sensitivity of cardiac myofilaments to calcium, has some PDE3 inhibitory effects similar to milrinone, but also increases intracellular cyclic AMP. It favors coronary, pulmonary, and systemic vasodilatation and can reduce PVR and improve RV function. It has a short half-life, but actually its effect can last for weeks due to an active metabolite with a 70 to 90-hour half-life. Dopamine, I think we'd all agree, is kind of on the outs in that it's an endogenous molecule that at low doses can cause inotropic and chronotropic effects through the beta 1 receptor, but at higher doses can cause vasoconstriction, and in multiple studies has not shown beneficial effect on renal function or outcomes. Norepinephrine and epinephrine are kind of in this inoconstrictor range that are vasoconstrictors but also have some inotropic activity and might be preferable in patients with mixed shock who are also hypotensive. So when and how should we use inotropes in right heart failure? Well, I think step one is really to step back and say, is there a need for an inotrope in the first place? Have I optimized their fluid status? Have I treated the underlying cause as possible? And then if you do decide that there's a need for an inotrope, what inotrope is most appropriate? And you might decide if the patient has mixed shock or low blood pressure to begin with of using inoconstrictor like norepinephrine or epinephrine. Whereas if the patient has renal dysfunction or hypotension, you might avoid milrinone. And then if you're concerned about tachyarrhythmia, using milrinone rather than dobutamine. And then I think the next step, too, is, what is this a bridge to? So you're starting inotropes in a patient with right heart failure in the ICU. What's next? When can you wean the inotrope? And so long-term, we know that inotropes are associated with increased myocardial oxygen consumption and possibly increased mortality. There's little data in right heart failure, and the guidelines generally recommend recommend against long-term use of inotropes. And so you should think of them as a therapeutic bridge to recovery or transplant, depending on your clinical scenario. And so is there a role for inotropes in right heart failure? Well, I haven't presented a lot of convincing evidence, but I think, yes, there is. And that's because, common sense, clinical experience, physiology, guidelines say, there is an important role for inotropes in our patients with right heart failure. But I think there's also, more importantly, an unmet need for well-designed randomized control trials to help guide use, or at least prospective studies, multi-center prospective studies to better understand critical care management of our patients with right heart failure who are admitted to the ICU. And so some key points: consider inotropes when there's evidence of inadequate oxygen delivery despite optimizing RV preload and afterload and systemic perfusion. Our options include milrinone, dobutamine, dopamine, norepinephrine, epinephrine, or levosimendan, but there's really a lack of high-quality evidence for use in right heart failure, although the guidelines typically recommend considering use of dobutamine or milrinone. And this is my email address if there's any questions later, and happy to discuss in the end.
Thanks a lot, Hilary. That was great. John is at a table here, and we were discussing later, but the bottom line is with the two talks, you discussed very important topics, but these are approaches that simply buy us time. They don't solve a problem, and they will only work if we have a chance to solve the problem. And the same is basically true for the next one, which will be mechanical circulatory support. And this presentation will be given by Dr. Kanwar, and you run the end-stage heart failure program, the MCS program, and the cardiac transplant program in Allegheny. I hope you pronounce it correctly here, hospital.
Yes,
so
absolutely.
It's a pleasure to have you here.
Thank you, Marius. So I was, during the break after the first session, I was looking for the queue that signs up for people who feel a little like they're imposters in this wonderful forum. And I thought, I'm here for one of two reasons. The first reason could be because I was recently showing pictures from my hiking trips to my mentor, Ray Banza, who taught me everything about pulmonary hypertension that I know. And he gave me the best compliment a mentor can give a mentee, which is that I have the best RV contractile reserve of anybody he knows. So I was like, oh. And then he convinced me to sign up for Mount Everest hiking, a base camp hike with Dr. Waxman. So I was like, maybe that's why I'm here. But then I thought, well, that doesn't make much sense. So I guess it is the other job description I have, which is I'm a left heart gal, so to speak, who dabbles in pulmonary hypertension. I take care of patients on both temporary and durable mechanical circulatory support, as well as run the heart transplant program at Allegheny General Hospital. And with that background, as I was listening to the first session and the amazing level of evidence that was being provided, I was getting progressively alarmed. And to follow Bradley and Hilary, I can tell you that level of evidence is just going to go downhill as this session progresses. So how do I approach acute RV failure when I'm thinking about possibly temporary mechanical circulatory support for the right ventricle in a patient? Of course, the first thing is to understand what is going on with the patient. Is this primary RV failure in a patient with either, let's say, pulmonary arterial hypertension or pulmonary embolism? Or is this a patient presenting with LV failure who also has RV failure, in other words, biventricular failure? And frankly, in the LV failure world, we used to traditionally underestimate the role of RV failure, focusing all our devices and therapies on the left ventricle and kind of not recognizing the role RV failure has to play for it. But recent work has supported the fact that almost 50% patients with LV failure in cardiogenic shock present with BIV failure, and congestion is probably almost more prognostic of mortality in LV cardiogenic shock as compared to hypotension or hypoperfusion, because we know sort of how to fix hypoperfusion and hypotension in these patients, but then understanding that these patients need to be decongested in a biventricular fashion is often underappreciated. Then, of course, understanding the severity of this state of that the patient is in. Using terms like, oh, this is a train wreck, or this patient is shocky, or just doesn't look good. That doesn't really help us quantify what level of severity this patient has in terms of cardiogenic shock. The next, of course, in the RV failure world is this from a reversible etiology? Because if it is so, then really the attention should be placed not on which device to use for this patient, but can you quickly reverse the etiology, why they are in the fulminant RV failure stage, before we start picking support options. So really the support options would be derived from, I would say, a series of these decisions that would need to be made at the bedside in a fairly rapid fashion, so we can understand which patients, if any, benefit from temporary MCS support. And this is nothing you haven't heard already. RV failure, to a clinical person like me, it's a hemodynamic problem. And if you do not address the 4 pillars of those hemodynamics, the preload, afterload, contractility, and leucotropy, you're not doing your patients a favor. So just jamming in an RV support device, which maybe unloads the RV, is not going to be sufficient unless you also have given this patient adequate amount of preload reduction, either with pharmacology or with renal replacement therapy, et cetera, but understanding that the RV is exquisitely sensitive to afterload and recognizing what the role of these devices in that particular aspect of RV failure management may be key. And I'm not going to insult your intelligence by going over what has already been discussed in the earlier sessions on how to assess RV failure, be it invasively with our hemodynamics using a Swan catheter or using echocardiography. Usually MRI, of course, in an RV failure crash and burn patient is not a modality we can use quickly or safely. But within those parameters, understanding that the PA pressures alone, just looking at, the PA pressures are low, of course, could be a very alarming situation if it's happening at the expense of an elevated CVP. So really, I would say it's the RA pressure, and then the other derived hemodynamic calculations. Probably in the left heart world or in the BIV failure world, the 2 most commonly used hemodynamic metrics are cardiac filling pressure, which is your CVP to wedge ratio, and also the PAPI, which is your pulmonary artery systolic minus diastolic pressure divided by your RA, to understand how sick the RV is in these situations, and commonly used in circumstances post-AMI, in LV failure, LVAD shock, et cetera, et cetera. And then, of course, there are all these other plethora of metrics that would guide us into understanding which are the patients that would benefit from temporary MCS therapies. And of course, the gold standard of all assessment of RV failure is PV loops. Again, easier sometimes said than done, but understanding the pathophysiology, because if we cannot define why the patient is in RV failure and do not understand what it is doing to their pressure volume loops, to try and move these loops to their normal state of affairs. So here you can see them in hypocontractile volume and pressure load respectively. If you don't understand the physiology behind RV failure, then just hoping the therapy you chose for the patient is going to stick usually does not work. And this was just presented earlier from the previous recommendation guidelines. But what I would like to highlight is a very succinct but valuable way of looking at MCS is ideally you want to have an awake ECMO. So you don't want to intubate these patients in fulminant RV failure, because once you combine sedation with the afterload that the PEEP or the increased pressure ventilation will present, that is really potentially going to kick the RV down the spiral if it hasn't been already. And then second, but probably more importantly, what is this a bridge to? Putting a patient on a device is easier than deciding what to do with and how to remove that device. And frankly, in my role as somebody who runs a shock program, half of my effort is spent in convincing my colleagues to not put patients on devices rather than to put patients on these devices. Because if we do not have an exit strategy, then putting these patients on temporary MCS with really nothing to offer them on the other side, I think is a cruel and unusual punishment. So this is probably, I would say, my most important, or I would say take-home slide here is understanding which temporary MCS to use really is about understanding what is the risk to the patient, for the patient, as in the operative risk. Because again, if you don't have an exit strategy, be it lung transplantation, so at my program, we don't do lung transplant. So I can't just put somebody with end-stage PAH on ECMO and then not have a plan to then transfer this patient to somewhere that may offer that person lung transplant, but also understanding that for example, in the RV failure world, I can support the LV with many, toys and gizmos that are durable, but then I can't support, there's no such thing as a durable RVAD that I can say, well, I'll just transition, or nothing at least on label. Secondarily, understanding what the patient's goals are, not just what your goals are for those patients, but understanding what the patient's goals are for that particular circumstances, because again, putting patients on temporary devices is irresponsible unless we understand how they're going to come off of it. Of course, assessing the severity of RV failure. Often, if you just talk to it nicely, diuresis the patient, use the right kind of inotropes and pressors as were shown in the previous slides, the RV starts to listen. So jamming in a device in somebody like that is not necessarily the right thing to do. Does this patient need oxygenator? Does this patient need BIV support? What is the need for the patient? But then also, if you are going to, let's say, take them for an Impella 5.5 support, which is often a circumstance where a patient presents in BIV failure, we take them to the OR, intubate them, sedate them, and do an axillary cut down to do the 5.5, which will, of course, support the left ventricle, but is the RV going to pay the price for it? And the patient needs to come out on, let's say, BIV support devices. So in circumstances like that, it is key to make sure the patient is as well medically optimized using either pressors and or inotropes and preload reduction as much as possible before you subject them to these therapies. Now, there are many review articles out there. This is an example of one of them where they talk about, again, defining the needs of the patient. Does the LV need to be supported? Does the patient need to be oxygenated before you decide which particular machine to use? But the key here is you want to be able to answer, what do you hope the pump will do for the patient? Because if you cannot answer that question, and I paraphrase my shock mentor, Naveen Kapoor from Tufts, not too far from here, is he often will say, pumps will pump blood. So if you say, oh, I put a patient on RP and the patient died anyway, is it really the RP's fault, or is it the decision that you chose to put that patient on RP that is to fault, so to speak? So know the pumps before you start using these pumps, because these are very expensive, invasive, and really sort of, they tear these vessels apart. And if you don't use them carefully, you can cause more harm than you can good. And making sure that you can articulate the needs of these patients and then match the pump to the patient, and not just say, I'm an Abiomed person, so I'll just put everybody on RP, or I like Protect, so Protect for everybody, is not the right way to go, so to speak. And this is probably, in essence, the physiological principle one has to understand before you match a continuous flow RV device to the need for the patient, and which is really the HQ curve. Which is revolutions per minute, which is device specific, of course, divided by the pressure head, which is if you subtract what is the pressure at the inlet, and then the outlet is the pressure head. So for example, if a patient has end-stage pulmonary hypertension, these are patients who will have high PA pressures and high CVP. So your pressure head is going to be different than if a patient's, let's say, coming in acute RV failure, let's say pulmonary embolism, where the PA pressures haven't risen much, but the CVP is still high. So here your pressure head curve will be very different. So the flow of the device that the device can give you is going to be very different in an acute PE circumstance as compared to patients with end-stage pulmonary hypertension you're supporting on these devices. And really the goal here is you're trying to move this patient from a high pulsatile load, which is their RV failure, to a better PA pulsatility. So here you can see an example of a patient who has severe RV failure, as is documented by the CVP of 22 and a very dampened waveform. After introducing RVAD, initially at a high flow and subsequently at a low flow, this is manipulating their RV stroke work index, and progressively you can see the increase in pulsatility of the RA waveform and the PA waveforms as the CVP starts to come down. And understanding, again, the change between this pulsatile load to PA pulsatility, I think, is key. And then, of course, learning the devices themselves. So we really have kind of, broadly speaking, two choices. You have a direct RV bypass, in which case you take the blood from the right atrium and place it in the right atrium, in the pulmonary artery. An example of this would be an RP impella or a tandem heart, for example. Or you have an indirect RV bypass, which is ECMO, either VV or VA ECMO, where you're taking the blood from the RA and putting it back into the aorta. And understanding what these do to your pressure volume loops, I think, is key. So let's just spend another 30 seconds on learning about that. So if you take a direct bypass, which is your RA to PA, what you're basically doing is once the device is inserted on the right side, which is represented at the bottom, your CVP should start coming down pretty quickly, shown here in red, and your PA pressures would be suitably augmented because you're bypassing the right ventricle and pushing blood directly into the pulmonary artery. Whereas if you're using a VA ECMO, which is your indirect bypass, your CVP will come down, but the PA pressure is not so much. And on the left side, it is going to create a high afterload for the left ventricle, augmenting both the LV and the AO filling pressure. So understanding what these devices do to the physiology of the patient, of course, will be key. So let's talk about these devices quickly. Again, I can't go over all the details that you would need to know, so I'm going to give you rather superficial, but sort of top 3 things to know kind of a deal. So at my institution, the most commonly used RV failure device is Protect Duo, and the reason we choose this device over others is primarily because it allows for ambulation for these patients. We now routinely ambulate patients as long as they're not intubated, even if they are on VA ECMO. But also having a device that does not, bind them to the bed is key, as these patients need longer and longer time support devices. So this is usually our go-to, especially in a post-cardiotomy RV shock stage. Typically placed through the jugular venous. It's a large bore access. It almost looks like this patient, we came up with this thing that just looks like a crown that you have to do to stabilize these patients as you ambulate them, but it does allow that luxury to be able to do that. But of course, at the risk of, it's a very large bore cannula on your SVC and can jeopardize the flow to that. The RP impella, traditionally placed through the femoral vein, is a smaller bore device, can be used for, I would say, shorter term support in, let's say, an acute MCS RV failure or in a patient with BIV failure. The new flavor in town is a bipella, which is that you have a patient with severe biventricular failure, you support the left side with their 5.5 and the right side with an RP device, allowing both these devices, both these ventricles to be decongested simultaneously. But of course, this is, easier said than done often. And once you put a groin access catheter, of course, it's harder to ambulate these patients. So now they have come out with an RP flex, which is an impella to be placed through the jugular vein, which will take away the limitation of groin access and therefore inability to ambulate. Of course, comes with the risk of thrombosis, as do all machines. And again, this is sort of a repetition of the first slide that I'd showed, but I just want to emphasize this. What does an RP or a tandem, anything that is a direct RV bypass, do? It lowers the CVP, it augments the pulmonary artery pressure, and in doing so, unloads the right ventricle. The RV is now able to fill the left ventricle better, and the blood pressure also starts to go up. And this happens within minutes of insertion of these devices, or should happen. The next device, of course, comes in many different flavors as VA ECMO, can be accessed through different devices depending on the, or access sites depending on the need for the patient. We obviously always try to avoid double groin cannulation if possible. because these patients, again, the usual adage used to be once you're on ECMO, you got maybe a couple of days before you can get them off of ECMO, but now we are routinely supporting patients on VECMO for longer and longer times because we have learned how to axillary or cannulate these patients more upstream and ambulate these patients despite being groin access as well. But of course, this is a very invasive device, large bore cannulas, and associated with its own risk factors. A classic patient that I would put a patient on VECMO with primary RV failure is a massive PE patient as we're trying to figure out how to get rid of their clot burden. Like I said, since we don't have a lung transplant program, I would try to avoid patients with PAH, putting them on ECMO unless I have a clear reversible etiology that can lead them to come off of the ECMO. And again, you are improving their right atrial pressure to an extent, you're unloading the RV. You are not necessarily impacting the pulmonary artery pressure, but you're substantially augmenting their blood pressure by putting them on VA ECMO support. Of course, there are surgical RVADs typically seen, and these are patients who are often in BIV failure that need a long-term either bridge to transplantation or sometimes bridge to recovery. A classic example is a patient who is undergoing a durable LVAD who is placed on either a CentriMag device or other devices, as we lovingly call them, HeartMate 6, which is 2 HeartMate 3 devices, 1 in each ventricle. Of course, an off-label use, and I don't think is available beyond anecdotes at best. And these are all surgically implanted devices. Once again, these are highly invasive devices, should not be used just on anybody or just by anybody. They do limit these patients from a mobilization standpoint, even with best intentions. They are, of course, very expensive, and there is little, if no, evidence available behind the use of, frankly, most things we do in cardiogenic shock, be it the left ventricle or the right ventricle. So with that, I will conclude when thinking about a temporary MCS in a RV failure patient, just remember the hemodynamics of the right ventricle, because unless you are able to articulate the need for the patient and match the pump with the need for the patient, you're probably not going to have a good outcome and instead end up blaming the pump rather than your own decision making. And again, it's never going to be a single number like a CVP above X or a PA or a PAPI below Z that will tell you this is a patient who will definitely benefit from it. As with all things in cardiogenic shock and other things we practice, multidisciplinary team approach using your cardiothoracic surgeons, interventional colleagues, and heart failure colleagues, as well as critical care faculty as well, I think would be key. But understanding and respecting a right ventricular failure, whether isolated or in the setting of an LV failure, I think can allow us to pick individuals who may benefit from temporary MCS devices. But my parting shot to all my fellows always is, don't be in a hurry to put in a device, because once you do so, you'll also have to be responsible for taking it out. Thank you for your time.
Okay, and last but not least, we have Dr. Nirmal Sharma talking to us about cures or exit strategies for the right ventricle. And specifically, he'll be talking to us about how and when is the RV too sick for lung transplant. Dr. Sharma is the current medical director of lung transplant at Brigham and Women's Hospital. And after medical school, he completed training in New York, followed by additional training in pulmonary critical care, lung transplantation, and mechanical support at the University of Alabama, where he practiced for a time before he was recruited from Florida. And as I said, he'll be talking to us about the RV and lung transplant today.
All right, folks, you can all see. So I know I'm standing between lunch and you, right? So just to motivate you a little bit, let me give you a nice joke to start with, okay? Any surgeons in house? No surgeons, right? All right, that's good. We can make certain jokes. So, whenever we're in the post-operative phase of lung transplant, and, I ask one of my surgeons, why did you do this, Or I ask them pre-transplant, do you think we should go ahead and transplant this patient with antibodies or, difficult medical issues? They say, well, I'm a simple surgeon, man. I don't know. I don't think it's a good idea. So they don't really look at anything. So fast forward when we have a tough case with pulmonary hypertension, complex RV, we have no clue whether the RV will recover or not. So we ask Dr. Waxman or we ask Brad, and they say, well, the echo shows RV has got a strain, drain, and brain. And you wonder, what the hell it is, drain, brain. So we say the same thing. We say, well, I'm a simple transplant pulmonologist. I don't know. I don't think the RV is going to recover. So the talk is essentially, we do not know, but I'll try to do some justice to the talk by trying to review the literature as to what is known and what are the knowns, unknowns. Are there any kind of hints that can tell us, when the RV becomes too sick for transplant? So these are my relevant disclosures, but nothing to do with the talk today. So, I'll discuss a case. It's one of my cases from my last practice, severe PAH with RV dysfunction. And the question is, why is the RV function important for lung transplant? I think that is a sentinel issue. Why do we care about, if it all becomes better over time, is there any imminent risk after transplantation? And are there any predictors of post-transplant RV recovery? And the question, does RV recover, and when does it recover? And when do you consider heart-lung transplant versus a lung transplant in patients who have very severe RV failure? So I'll give you some thoughts there and some flavor. So let me start with this case. This is a very, I would say, motivated young woman who came to our practice. She was 47 at that time with 3 children. And she had IPAH and was recurrently admitted to our hospital. She kept on coming for RV failure, but really was managed by inotropic support and diuresis successfully most of the time. And one fine day, she never suggested, nobody ever suggested transplant for her. So one fine day, I was in the cardiac ICU, and we got a call about a patient who was in the medical ICU. And she was a 47-year-old with severe IPAH, and she was in massive RV failure and multi-organ failure. So we were asked, would you be able to transplant this patient? So certainly looking at a patient who was on maximum inotropic support, her LFTs, as you can see, they were between 700 to 800, believe was 4.5, creatinine. So she had multi-organ failure at this time. So we started thinking, how do you get somebody who's in such extremis through transplant successfully and good on the other end? So you go back to your physiology. And if you see here, I have a echo here. Let me see if it works. So anyway, this is a static image. So in the static image, you can see the first one on top is when we got the consult. And you can barely see the LV. It's just all RV there. And then, we said, this is a young lady, so let's go ahead and see if we can, reverse some of these acute changes and get her through transplant. So we went ahead and did a central VA ECMO, and with a special design where we went, right atrium to the left atrium. That was AA ECMO that we initiated. And we continued to diurese her, support her, and ambulate her. And over a period of time, her liver function became better, her renal dysfunction became better. And then we went ahead and transplanted her. But the conundrum here was, the lady had, RV dysfunction for a very long time. We were not sure whether the RV would recover. This was chronic RV dysfunction. So the question was, would it be better that we go ahead and do a heart-lung transplant for this patient compared to just lung transplant? There was no data, when you reviewed the data, there was nothing, there was no clear indicators. But thought in the mind was, this is a young patient. Perhaps she'll do better with heart-lung transplant. The second thing, can we get her a heart-lung transplant? Is, giving 2 organs versus 1. So we'll talk about that in later slides. So nevertheless, the other issues were, will we have more post-operative issues in this patient immediately after transplant? Will we run into, early graft injury? So a lot of things came into the mind, but ultimately, the fact that with the ECMO, with inotropic support, diuresis, we were able to reverse renal dysfunction, we were able to get the liver fine, we went ahead and did bilateral lung transplant. And I'll tell you what happened with her in the subsequent slides. So answering the first question, what are the risks with RV dysfunction and increased PA pressures after transplant? So I'll introduce the concept of ischemia reperfusion injury or primary graft dysfunction that we call in the lung and the heart world. So essentially, ischemia-reperfusion injury, or PGD, means that after transplant, the lungs get flooded with fluid. Inflammatory, rich fluid gets into the lung, and as a result, the lungs don't work. You have longer ventilator times, and you might need post-operative ECMO, and ultimately, you can say more ICU stay and more morbidity and mortality. So this is small, but if I can point out, let's see here. So this is a paper which was published almost a decade back, but a lovely prospective trial of 10 centers. It was run by UPenn, and they did a prospective trial to understand what were the risk factors in patients who develop PGD. And you can see here, I won't bother about all these other donor factors, but this is recipient pulmonary hypertension. And you can clearly see as you became, you had more severe pulmonary hypertension, the risk of this primary graft dysfunction went almost to 40%. So it was pretty clear that, PGD and pulmonary hypertension were linked together and had a very robust correlation there. And then the question was, what happens to the PGD? If you do develop PGD, what exactly happens to you? So if you do develop PGD, then your risk for in-hospital mortality and long-term survival, is reduced. In-hospital mortality increases. So it's a grave problem. We want to do everything possible to reduce PGD. So the next question was, are there any other parameters that could inform us whether a patient will develop PGD or have increased risk of mortality? So this is a manuscript which was published out of Cleveland Clinic. And in their cohort, what they looked was they said, okay, what are the pre-transplant factors that can determine PGD in terms of pulmonary hypertension? They didn't find any. But what they found instead was that if your PH and RV dysfunction persisted after lung transplant, then you would have a bad time and you would have increased mortality. So you can see this here. If you had no PH, no RV dysfunction after transplant, compared to if you had some persistent PH and you had ongoing RV dysfunction after transplant, there was a pretty significant reduction in survival there. All right. So the next question is, are there any predictors of poor post-transplant recovery? So, this is the slide I showed you before was post-transplant metrics, but now let's see, are there any pre-transplant metrics? So, common thought before 2013 was, if you have high PA pressures, and if your RV doesn't work, that means if your RVEF or RV, work index is low, then we always, in the field, people thought that these are the people who will end up with pulmonary hypertension. So a study in 2013, done in New York, Columbia, their hypothesis was that if you have poor RV function and high mean PAP, you would have more PGD. They were surprised. Their data showed that if you had high mean pulmonary artery pressures and lower, RV indices, that means if your RV was working suboptimal, then you had a lower risk of PGD. However, if you had higher mean PAP with a good working RV, you ended up having high grades of primary graft dysfunction or ischemia-reperfusion injury. So it was completely opposite. So this work was taken further by a group out of Europe, out of Spain, and they looked at this in a retrospective and prospective fashion. So I'll share that data with you. So in their cohort, what they did was they tried to ask the question. They found a very similar association. If you had, higher mean PAP with a more working RV, then you were at a higher risk for primary graft dysfunction. But then they looked at different indices. So if you can see, TAPSE is our favorite. I mean, none of the lung transplant guys understand TAPSE, but we love to quote that all the time. But the reality was there was no difference in TAPSE. But there were other things which actually came to light. One was the longitudinal strain percent. So if you had longitudinal, there were differences in longitudinal strain percent between in the basal region between those who did not get primary graft dysfunction versus those who got primary graft dysfunction in high grade. So certainly this study showed that this is the prospective part, and this is the retrospective part, you can see even in the retrospective data, they found that the basal longitudinal strain was different between those who developed PGD and non-PGD. And when they looked at the same cohort in a prospective fashion, they were able to find this. And further, they also found that overall strain rate was higher in the basal region in those who developed primary graft dysfunction. So let's look at other metrics. So if you look at this, cardiac index, so if you had lower cardiac index, you were actually protected from primary graft dysfunction compared to if you had a higher cardiac index. So really, 3 studies, telling exactly the same story. So it really changed the way we manage. And I'll tell you how we thought about it and how we, introduced change in the field. So the 3 studies essentially said regional impairment of RV basal segments predicted severe primary graft dysfunction. And if you had a high mean PAP and high RV stroke work index, it was associated with worse outcomes. And lung transplant is the same thing. If lung transplant better RVF had a higher risk for PGD. So the next question is, that's great, but does the RV recover after lung transplant, or when does it recover and how does it recover and how long does it take? So this is a very old paper from 1996, and this was done at Columbia. And they looked at different parameters, and if you see here, they looked at RV end diastolic area, systolic area, fractional area change of the RV. And you can clearly see that pre and post-transplant, these indices became better. So you could see end diastolic area reduced, fractional area change actually improved, suggesting that the RV was working much better. And of course, paradoxical septal motion also reduced here. Now, next question they asked was, all right, that's fine. Are there any people, so there were at least 4 or 5 patients in that cohort that did not recover after transplant. So they tried to characterize those folks, who did not recover. So if you see those who improved after transplant versus those who did not improve after transplant, you can see that their preoperative PA pressures, this is preoperative systolic and diastolic, you can see that those who improved had a higher PA systolic and diastolic, at least in their study. And then the same thing, if you look at the RV and diastolic area, systolic area, and RV FAC, you can clearly see that those who did not improve, even pre-transplant, had poor RV FAC. So a little bit contradictory to the more modern studies. But nevertheless, they suggested that after transplant, your lung function does improve. The RV function does improve. So this is from our group. This is from our surgical group. So we asked the same question. After transplant, what happens to the RV? So we looked at different parameters here. You can see that we looked at the RV basal diameter, RA diameter. We looked at the tricuspid regurgitation, velocity, and all these indices after transplant in a pretty decent cohort of 40 and 30 patients actually improved. And these are all patients who had severe RV dysfunction or pulmonary hypertension pre-transplant. So certainly it seems that the RV does recover after transplant. Now, another study took it to the next level. They said, all right, we want to use imaging to see what happens to the RV. So this is out of Europe. And these folks did cardiac MRIs before and after transplant. And you can see the various indices that they showed here. So it's a little bit small to see, but you can see that this is RV end diastolic volume. And you can see pre-transplant and post-transplant, there's a reduction in that volume. RV-EF improves, and this is all based on cardiac MRI. RV-LV ratio, you can clearly see that it reduces. And then here, this is RV mass index, it goes down. Stroke volume by end systolic volume improves, and RV-LV mass ratio reduces. So really great correlation, visually, that the RV actually improves. And this is just a representative image. You can see, how the LV is barely there pre-transplant in figure A, and RV and RA are predominant. And post-transplant, you can see that the LV starts improving, and RA and LV diameter reduces. And then they looked at other metrics. They basically looked at the tricuspid valve annulus. They measured that, and you can see that that also post-transplant reduced. And tricuspid area also reduced. And you can see that there is some solid lines and dashed lines. the dashed lines and solid lines essentially represent the sickness or severity. So in all severity, whether you had lower severe, WHO class 3 or class 4, regardless, you improved after transplant. So essentially, till this point, it was pretty clear that RV does recover. And in their study, the median time of recovery was 8 months. Even though, and this is through cardiac MRI and echocardiogram. So we see in our clinical practice that the RV starts functioning right away after transplant. We see the indices of pulmonary pressures, et cetera, improve right away. But imaging-wise, sometimes we see even after 1 year an echo showing mild RV dysfunction or moderate RV dysfunction, but the patient is absolutely fine. So really, telling the point that it takes some time for complete remodeling and improvement in the visualization. So, I'll tell you about these in the next slides. I think that'll be much better. So the next question is, when is a heart-lung transplant better than a lung transplant alone, right? So what are the challenges in the field? When you have two organs to give versus one, there's always issues with equity. There's issues with access. So this is historic data. This is out of Stanford. This study was done from Stanford in 2015. They essentially looked at all the patients in the UNOS registry. So it's over 1,000 patients with pulmonary hypertension, around 700 got double lung transplants, and 250 or 300 got heart lung transplant. And they asked the question, is there any difference in survival amongst these patients, with heart lung transplant or lung transplant? And mind you, all these are IPH patients, high PA pressures, RV dysfunction. So they didn't find any difference except in one cohort. And the cohort was those who were hospitalized in the ICU. So if you were hospitalized in the ICU, you getting a heart-lung transplant made you, better in terms of post-operative survival and long-term survival. And we can talk about why and what may be the reasons for it. In the next slide, I'll give you some thoughts in that way. But on and all, double lung transplants in all other realms, whether you did a double lung transplant or a heart lung, they all fared exactly the same. So the authors, certainly there was no evidence, but they thought that maybe this is due to the reduced risk of primary graft dysfunction in folks who had heart-lung versus lung alone. So now, thinking about this, so we'll go back to our first slide there. We said high PA pressures, and you have a very good working right ventricle, and there is increased risk for primary graft dysfunction. Why is it so? So a few years ago, there's a manuscript which was published, I think, in JACC, and the manuscript essentially looked at a few metrics. One, they looked at a cardiac MRI, and also they took biopsies from patients who had normal, heart function and without any PH, or from cardiac donors, essentially normal cardiac donors, and they also took biopsies, LV biopsies from patients who had PH. And they tried to answer a question. They said, all right, is there any difference between the contractility of the myocytes, the thickness of the myocytes, and also the myosin content of the myocytes? So they were surprised to find that when you had chronic pulmonary hypertension, the ability of your myocytes to contract was at 30% compared to those without pulmonary hypertension. Number two, what they found was that the myosin content of myosin by actin ratio or myosin content of the cardiac myocyte with chronic PH was much lower, was 0.3 compared to 0.9 and 1 in those who did not have pulmonary hypertension. So on and all, it meant that the cardiac myocytes with chronic pulmonary hypertension had become atrophied. So there was an atrophy. So what does atrophy mean to us? It means that there is more LV stiffness. And when you have more LV stiffness, what happens? When we see an echocardiogram, we sometimes see a smaller LV and diastolic volume, suggesting that there is this chronic low flow state. And after transplant, when you fix that pulmonary pressure issue, and when there is a gush of blood going from the right ventricle to the left atrium, what happens? Suddenly you see this diastolic dysfunction, LV stiffness phenotype come in, and there is back pressure right away. And that back pressure goes back into the lungs. And one of the physiologies of a new lung transplant is where we connect the pulmonary arteries. That area in animal models have been shown to be, the vascularity, it's very, very permeable. So any back pressure that comes from, the left side essentially means that your lungs get flooded, the new lungs get flooded with fluid, and that essentially is primary graft dysfunction for you. So thinking about that concept, that is the reason why we, end up getting PGD. And so thinking about this, if you have a patient who has a very good working right ventricle with high PA pressures, right, compared to somebody whose, RV is a little bit sluggish, somebody who has an RV which is working very well, suddenly you open the floodgates. There's a massive, flow of fluid from the right to left. And that's just hypothetical. There's no data to support that, but that's what we see in our clinical practice. And then you run into this LV stiffness and increased primary graft dysfunction. So thinking about this, how do we address this? So this is a group out of Germany. They said, all right, how about, just like chronic pulmonary hypertension and CTEF surgery, they bring the patients out on VECMO. They said, how about we bring patients with, chronic pulmonary hypertension with, low LV and diastolic volumes and potentially cardiac atrophy out on VECMO and see what happens to them. So what they did was, this is just, one of the patients that they have shown. So if you see, 0 is the time point when they were actually put on ECMO. So if you can see, their PASP was high. After transplant, of course, this is still on ECMO, VECMO. Their PSP went down. Their ejection fraction, LV and RVEF, you can see the RVEF rapidly improved after transplant. LVEF took a small dip, but then started improving here. And then cardiac output slowly started improving here. And then these are other metrics, end diastolic dimensions, et cetera. And you can see these are at two different flows. So essentially they were saying, what is the right time to wean off the VECMO flow? So what they did was they went ahead and reduced the ECMO flow. So you can see they went down to 0.6 here versus full flow of 3 liters per meter square. And you can see that when they started reducing the flow here, on POD2, your end diastolic diameter actually increased, suggesting that the patient was not ready to be weaned off the VECMO. So they continued this patient for a long time. And then by day 5 to 6, all the metrics started getting better and the patient improved. Same thing with the LA, same thing with the, LA pressures here. So essentially, in their study, what they found out was that if you did this controlled reperfusion of the LV, then you could actually reduce the risk of PGD. So here is, when they compared it with those who had bilateral lung transplant with regular standard of care, you just brought the patient on ventilator, compared to those who came on VECMO, compared to some historical cohorts who did a heart-lung transplant. If you see here, their rates of PGD was lowest in patients who had this controlled reperfusion of the LV. And that also translated into long-term survival, and those patients had the highest survival amongst the cohort. So back to our case. So our case, at that time, we did not read this article, certainly, but we had no choice, because one of the biggest issues with transplantation is that the new system of organ allocation, it's very difficult to get a heart-lung block. We would love to do heart-lung block in every sick RV, but the access is an issue. It's an equity issue. Plus, in our region, to get a heart-lung block is near impossible. And with the change in the allocation system, it's impossible everywhere else. So we did a double lung transplant. We actually brought her out on controlled reperfusion. She recovered well. She was discharged to rehab in 2 weeks. And then post-transplant echo at 8 weeks showed marked improvement. And this is the post-transplant. This is a video, but you can just see here, RV compared to LV. You can see dramatic improvement in 8 weeks. So what are some practical considerations for us? When do we really consider? I have many other cases that I can share, but in the interest of time, what are some considerations to make when you're choosing heart-lung versus lung? So if you have chronic RV failure with frequent exacerbations, certainly you have to think through, and you can look at other metrics, but that may be one of the considerations that the RV may not recover after lung transplant. The second is prior significant cardiac surgery. So we had patients whose RV, is toasted, However, they've had previous cardiac surgeries and they've had, ongoing CADs. In those patients, doing a technically difficult operation, going back and doing a restenotomy, increasing the intraoperative perioperative risks make no sense. So in those patients, doing a clean heart-lung block certainly provides advantage. Then the presence of RV or LV scarring on cardiac MRI. I think this is the most important. We do cardiac MRIs on these patients, and if we see late gadolinium uptakes suggesting of scar or stiffness, those are the patients we know that long-term may not do, and they'll have a terrible time perioperatively. And there are some patients in whom you cannot, they have borderline LV function, but it's unclear, why they have that LV function. It's not explained adequately by their RV pressure volume overload, and they may have some intrinsic RV or LV dysfunction. Finally, surgical risk. I think that plays a very important role. Is the explant challenging? Do we perceive that the intraoperative course is going to be challenging? So we had one patient who unfortunately developed HIT. He had, his RV on ECMO when we weaned down the flow, was doing fine. Even with a flow of 1 liter on VECMO, the RV was squeezing very well. So we thought that, yes, this patient will be fine. But unfortunately, he developed HIT on ECMO. So we did, a double lung transplant for this patient. Intraoperatively, he required 100 units of transfusion, unfortunately. And he came out in a very bad shape. He didn't survive. But in hindsight, we thought about it and we said, perhaps if we had done a cleaner block for him, that might have, the RV was so behind that there was no way that it was able to take that load of the massive transfusion which the patient got. So again, different considerations to think about. So on and all, key points, take-home points. I mean, severe PAH and RV dysfunction certainly is a risk for post-transplant primary graft dysfunction, so which can impact outcomes. So it's very important to think about it. RV recovery occurs after lung transplant in majority of the cases with pre-transplant RV dysfunction. Controlled LV loading using post-operative VECMO may reduce PGD and improve outcomes, and several centers around the country are already doing it in large scale. And heart-lung transplant is reserved for a selected group of patients, those who have severe RV dysfunction in the setting of congenital heart disease, or if they have concomitant pulmonary cardiac involvement, for example, sarcoidosis. We do protocol cardiac MRI in those patients to see involvement of the heart. And those in whom RV dysfunction is not explained by pulmonary hypertension alone, if they have other issues, intrinsic issues, I think in those patients, certainly heart-lung transplant may be better. And finally, of course, based on the data, if they are in the ICU very sick, and on multiple support, and you think intraoperative course is going to be worse, then certainly consideration for heart-lung transplant is very reasonable. So thank you so much for your attention, and happy to answer any questions.
So we are running a tad late. We'll give about 10 minutes for questions before we go to lunch. So if you have questions, feel free to move to a microphone, and I will give you guys this one.
So I have a question for Bradley and Hilary. My question is, when you have a patient with active peripheral vasoreactivity, so Raynaud's, scleroderma, PAH, does that impact your choice of inotropes and the placement of a radial A-line?
Great question. So I do not think it impacts my choice for inotropes, milrinone versus dobutamine. I think I would be equally likely to use. I do think I'm more cautious with radial A-lines in our patients with scleroderma, but I wouldn't necessarily not do one if I felt like I needed it for monitoring. I think a lot of times we don't need an arterial line, and so avoiding that when possible. I don't know.
Yeah,
I don't think there's a right or wrong answer.
I agree. I think it depends how shocky they are and how badly you need your mean arterial pressure monitored. I might be a little bit more circumspect about going to high dose vasopressin, for example. Sometimes we'll go up to 0.08, but I might be a little bit more mindful there. It probably also depends on whether they're actively already digitally ischemic or something to that effect. But it's a great point.
Brad, did you say shocky? Just after my lecture, shocky.
Yes, I did.
I judge you, Brad.
Dr. Farmer.
So I just have a general question, and it was used several times during the talk, bridge to transplant. Okay, that's fine. And we run into the same issue when we have people admitted with pulmonary hypertension and right heart failure. Okay, they've not been evaluated for transplant. They aren't anywhere, we don't do transplant, so they got to go somewhere. Okay, so how do we get ECMO people to believe in bridge to treatment rather than just bridge to transplant? Okay, which is extremely important. Our ECMO people always say, hey, you don't have an out, we're not putting them on ECMO. Okay, we're not going to, the way I look at it, if we can do bridge to treatment to buy time to get them on to, whatever, because a lot of times they present on no meds or whatever, then that's important. But it's very hard to convince most ECMO people that if you don't have an out right in front of them that they can see, that they're going to put them on ECMO.
So I'll take the first swipe and maybe Nirmal can answer the second. So, I've been practicing for about 12 years. The last time I bridged to transplant was never. It was always bridged to medical therapy. Of course, it depends if you're therapy naive, new diagnosis versus somebody who's been on all possible therapies and despite that then presents an acute RV failure, in which case, hopefully, you're referring them for lung transplant way before they come to that situation. So the idea would always be figure out the tipping point. If they are therapy naive, you get them on therapy, be it IV prostacyclins, inhaled agents to bridge them, and inotropes just to get them to that point. And if they're already on therapy and failing, figure out why they're failing. Maybe it's something you can reverse. So to me, I use ECMO as a bridge to recovery because we don't have the
luxury of lung
transplants.
Come talk to our ECMO people.
Yeah. Well,
I mean,
I don't have those people.
No, it's actually very common. It's very common among, we've talked to other places, and it's very common among ECMO. If we don't have an out, they're not interested.
Yeah, I think rightly said, I may have a biased view because I've always been in transplant centers. So, we always believe in parallel, right? If we can, the reality is that transplant has a shelf life, right? Once you start it, there's a shelf life. So in a young patient, if we can squeeze a little bit more out of their lung or their RV, better for them. So what we have done in the past is we've had patients who came in with RV failure and PAH, put them on ECMO. They actually recovered, went home with 3-4 liters, and came back a year or two later for a lung transplant. So exactly what you said. But we had the reason we had no issues going and doing that was we knew that in case we have no recovery, we have an alternative at hand. So I think that is the benefit, but certainly it's not unreasonable if you truly believe that, with the advent of the modern PH therapies, you can, control them and you can make them put them in a decent spot. And then look, if there are transplant, if you have relations with transplant center nearby, I think this is a conversation you should have that, look, we're going to try to do this at our center, but if we go to a point where things are not improving, we might need your help. So I think that's the way to approach it.
Then the last point is, if we do all of this and we can convince them, a lot of the problem is, or some of the problems we run into, if we call a transplant place near us, they say, well, she or he's never been evaluated here. Unless they've been evaluated prior, we're not interested.
Yeah, I think that is a perennial challenge.
That's reality. That's real life. I mean,
flight into Hanover.
Huh?
We do that.
I got it. I'm putting them on a plane. Lufthansa, boom.
Hey, great session again. I wanted to come back to the conversation around double lung versus heart lung transplant. So full disclosure, Francois and I were involved in several of the publications, Transplant, Circulation, JAMA. And every time we try to bring up the issue of heart lung transplantation, the reviewers said, one, there is a heterogeneity of practice, that centers like Stanford, maybe Cleveland Clinic, do the most of any of the heart-lung transplants, so there is bias there existing. And secondly, there is a moral and ethical issue around giving two organs to the same individual versus allowing two individuals to get benefit from the single donor. So I wonder what's happening in the transplant world now to address the heterogeneity and the ethics of that question. The magnitude of difference between survival post-transplant with heart-lung versus double-lung is not that great. It is, but it's not that great. And when you have a matched cohort, you see that difference isn't that's profound as we think it is. But I wonder what's happening in the transplant world from a practical and practice perspective, because I think it's a really important question as we begin to see more and more end-stage patients surviving longer, getting to a point where the RV may look too sick for just a double lung transplant.
No, I think that's a brilliant question. Unfortunately, the field is moving in the negative direction right now. So just for everybody's, so the big centers that do heart-lung transplants, Alabama, UAB, Stanford, Cleveland Clinic, and that's the three big centers that do most transplants. And Stanford does like 15 a year, heart-lung. And around the country, there are around 40 heart-lungs a year compared to 2,500 double-lung transplants. So the challenge is that with the new allocation system, so regarding the equity first, right? Equity and all. Again, I'm sure many of you are cardiologists, so I'll just try to joke on you guys. I mean, I don't think it's an equity personally. I feel that it is better to give a heart-lung to the right candidate to ensure longer survival compared to giving them a double lung transplant and being a 2 or 3 year project, right? So the challenge is in the outcomes. If you look at the heart-lung transplant outcomes, in fact, the 1 year survival of heart-lung is actually lower than double lung transplant, unfortunately. However, the long-term survival is better. It's like 13 years long-term. So if you do make it out of the hospital in the first year, you have a very good chance of long-term survival. So that's where the data becomes a little bit gray. And there has been no consensus. And in the new scheme of things, it's called the new allocation system called continuous allocation, has made it even worse. So in the past, at least, we were able to do 1 or 2 heart-lungs. Now, you have to hit a minimum score in terms of your continuous allocation system to be able to get on the heart-lung list. And even if you get on the list, the allocation goes like this. All the heart status 1 and 2 within the 500 nautical mile radius get first dibs. And you know that once it goes to them, it doesn't come back. And most of our heart-lung patients are status 5, status 4 on the heart list. So unless until you are Stanford, where you have a very good relation with your OPO and with the other heart transplant programs and say that, look, our patient needs it, so why don't you relinquish the organ? It is going to become even worse. So we are coming up, as part of the lung committee that designed the CS, we are coming up with metrics to see if, when you have a certain level of sickness, let's say above 80th percentile on the lung list, should there be an argument made that, look, if they're on the heart-lung list, we should let the heart be given along, just like the abdominal organs. So heart trumps the lungs, unfortunately. So unfortunately, it's getting worse in the current era.
Is that even a consideration in Europe?
Yeah, thank you for asking that. I was going to comment from the European perspective and coming from a center that has performed more than 2,000 lung transplants over the years. There is almost no reason to do heart and lung anymore, at least for pulmonary arterial hypertension. These right hearts always recover. There's absolutely no point. And I also disagree with this is historical data that there's potentially better long-term survival. It's no longer true. The simple fact that makes all difference in management of these patients is the use of the ECMO, if needed prior to transplant, during the transplant instead of cardiopulmonary bias, and after transplant, because as you pointed rightly out at the end of your talk, it is not RV dysfunction that is the problem in post-transplant patients. It's LV dysfunction. It's LV diastolic dysfunction, which of course correlates to the severity of RV dysfunction. And that's it. And these left ventricles just need a couple of days to recover. So, and I think that changes everything. So unless you have a pathology that you can't correct, then of course you have an issue with heart lung. But otherwise, it's lung.
Okay, completely different topic. So this is for Hilary and Brad. So we heard a lot about why we shouldn't give volume, but nobody mentioned whether or not we should be considering transfusions, and especially for patients who have low hemoglobin levels. And I know, like in the left heart world, there's a huge controversy in the unit whether you should transfused up to a hemoglobin of 10 or whether or not you should just let the patients recover. And very recently, there was just the publication of a large trial that looked at this very question and literally just missed its p-value. for showing that transfusion to a hemoglobin of 10 would be, non-inferior to allowing the patients to recover. So how do you manage that in patients with PAH?
I'll try to take a stab at that. I think that's a great question, and I think we probably underappreciate anemia and iron deficiency and its impact on right ventricular function and RV failure in our patients who are admitted to the ICU and often have lots of comorbidities, maybe bleeding and other complications. We tend to be a little bit more aggressive, but kind of with an intermediate goal for hemoglobin of targeting more of a goal of 8. In addition to, if you're diuresing the patient, trying to balance transfusion and giving volume with also removing fluid if needed. And I think another thing that we tend to do is IV iron infusions, even in our hospitalized ICU patients, just to try and improve iron deficiency too, to balance that out as well without giving, again, trying to avoid lots of volume, but haven't taken an approach of, a higher hemoglobin target of 10 or something like that for our PH patients. But I think it's an interesting question.
Yeah, I think a number of, by virtue of the association with connective tissue disease, it's not uncommon to see a very iron deficient, pretty profoundly anemic scleroderma PAH patient who's sick in the ICU, and I think we need to tailor the resuscitation accordingly. But, I think it's going to be many, many days, considering how hard folks have fought and looked at transfusion thresholds in a general critically ill population, or even in cardiac disease where the clinical trial infrastructure is much more robust than those of us on like the MICU side of things, of smaller patient populations. It's going to be a day very far in the future before we have anything evidence-based to guide that.
So since you both raised it, what are you using for a definition of iron deficiency? Because in the left heart world, this is a big question.
So, I think I'm looking at integrative assessment of iron stores, ferritin ratio, CBC, and, especially if you see by the time the MCV is down, the horse is well out of the barn. You see that in the scleroderma folks a lot, but I don't think we even have a great assessment given the effect of acute phase reactants on iron metabolism.
I think the iron to TIBC and then the ferritin, I think, is kind of my simple marker for looking at IV iron, when to give IV iron using a ferritin like less than 35 to 40 or so, for thinking about using IV iron in the inpatient setting.
It's interesting. It's a little different in the left heart world. So,
echoing Jane's comment there, probably more the iron percentage, and not to focus on the ferritin might be. The other thing we didn't really talk about is a little granularity. If a PAH patient comes in and this PAH patient is on high-dose parental prostacyclins, because I think the management of both pressors and inotropes may differ a little bit, and sort of that's why when the question, came up, is it the same in everybody? So if somebody's coming in on, 75 nanograms per kilogram of prostacyclin, they're going to be a lot more vasodilated, and probably the use of things like dobutamine and milrinone, and certainly milrinone, might be fraught with more issues in that case. And then the other thing, we probably should, just think a little bit on the emphasis on, in terms of how we're managing these patients in the ICU. We don't really need, even though we've moved as a left heart, as a shock doctor, that, in the left heart failure, we definitely want the hemodynamics. In a known PAH patient, don't we just need the CVP and a venous sat to monitor which direction they're going? Those were some of the other thoughts.
Actually, that segues into the question I had, because I've always been against inotropes on these patients because I think of it as just increasing myocardial oxygen demand against a fixed output, a fixed afterload. Yet I think hearing the issues of SVR versus our pressures versus our function, maybe we're just measuring the wrong thing, and PVR may not be the thing we ought to be looking at because we calculate it, and PVR is going to look better if we make flow better, but it may not really be better. So what should we be following as we manage pressors and plus minus inotropes versus just going to mechanical circulatory support?
So I think those are both excellent comments and questions. In my practice, I tend to not have, all of my patients who I'm starting on an inotrope have a Swan-Ganz catheter in place, but generally they do have central lines. So I kind of use my cheap marker of cardiac output of the central venous O2 sat and following that with inotrope use to see if, is there benefit? Is their mentation improve? Is their urine output improve? Really taking all of those clinical parameters and my SCVO2 into account to determine if the inotropes are working. And if they're not working, if there's side effects, then I think that's when we need to stop them because of all of the different adverse effects that can occur, tachyarrhythmias. And it's an issue, I think, that's fraught with a lot of complications and heterogeneity in practice, where it's really hard to tell in these patients when they are developing hypotension, developing tachyarrhythmias, renal failure, and all of these complications. It's hard to really know whether your medications are working. So that's my simplified approach generally.
Yeah, I think the metrics for the kind of next generation assessment, next generation treatment targets of RV afterload, some of which we will hear about in the session to follow this afternoon. I think with the current technology, the current availability of hemodynamic monitoring in the ICU and so forth, I think I absolutely agree with Dr. DuBrock in that I think end organ function is the most important thing to follow in the ICU. Whereas I think in the compensated outpatients where you're trying to follow more complicated treatment algorithms or risk stratify over the long term, at least that's when I think starting to think about the other contributors to RV afterload, the beyond PVR, the compliance, the other factors determining impedance, pulsatile reflection, so forth, some of the deeper order hemodynamic phenotyping may have the most bang for the buck. But it's a great point.